All right, we are going to get going here. We have a lot of great content, so I want to make sure we get through it and also have a little bit of time for some live Q&A at the end. So first off, thanks again for joining us on today's webinar, COVID-19 Billing and Coding Updates and FAQs. You do, if you are attending this live right now, you do get one AAPC CEU for attending it live, and so we'll make sure to send that out to you through email following today's webinar. As usual, everybody is on mute, but if you do have questions for us for the end of the presentation, you can submit those through the Q&A panel. We have quite a few attendees today, and so please submit those to the Q&A panel and not the chat panel if there are questions related to the topic discussed today, as that will keep us organized to make sure that we do get to your question or at least see it. If we don't get to it, we do answer all questions following and make sure to send that report out as well. With that said, today's presenter is Ardith Campbell, and she is one of the content and regulatory wizards on our team at Vitalware. Officially, she is the content product manager here at Vitalware. And Ardith, I'll hand it over to you.
All right. Thanks, everybody, for taking time out of your day to attend the call. And I just kind of wanted to get some stuff together just to give you some updates and go over some of the frequently asked questions that come in. First off is our basic disclaimer statement. This is just an update, and it's current as of today. We're not exactly sure what will go on tomorrow, but as of today, this is the info that we have and that it's good. So our basic agenda is we'll cover some of the new ICD-10 PCS codes that came out. Published July 31st, that they were effective August 1st. Thank you very much. And we have some new CPT codes. And then we'll touch on the evaluation and management versus the originating site fee for facilities. That's one that we get a lot of questions on. And so then we'll go over some other items and other frequently asked questions that come in. And then I also wanted to talk about some of the proposed rule topics that are resulting from the COVID-19 waivers and flexibilities that were published in the outpatient prospective payment system rule, and also the Medicare physician fee schedule proposed rule. And I don't have any bullet points on this, but I will also add some details that I heard when I was listening to a webinar that was provided by the AMA this last Tuesday. So kind of going off the deep end here, we've got a new jack scalpel, so it's a new piece of equipment there, but it does kind of tie into some of those new PCS codes. And CMS has said that, you know, the facilities are already doing these procedures. They wanted to give you specific procedure codes so that you could can bill for these items. Now, one item I do want to talk about is the remdesivir. It has been given kind of an emergency use approval through the FDA, but only on an inpatient basis. So if you are giving patients the remdesivir that can be charged, there is no HCPCS code for the drug. So you can, you know, on the inpatient claim, it would just be charged underneath the revenue code. But if you did need a HCPCS, just use one of the not otherwise specified, but it usually gets taken off on the back end before it goes out the door. So these are for the introduction percutaneous approach. And then we've got like through the central vein percutaneous. So it's a lot of the same drugs, just different approaches and different technology groups. The ones, though, that I did want to touch base on are the bottom two on this slide, the XW13325 and the 14325. That is for your transfusion of your convalescent plasma. One's the peripheral vein, the other is the central vein. And during the last CMS office hours call, it was questioned, what P code would you use, or what would you use for the plasma itself? And CMS said right now the convalescent plasma is only used on the inpatient side, so it would not be used, so there would not be a HCPCS, so they do not have a HCPCS for this. However, the person with the question did say, but eventually we may be doing this on an outpatient basis, and how would we how would we report it then? And so they're taking that into consideration. So it's possible that in a future time, there would be a P code specific for convalescent plasma. Right now, they're just expecting it to be reported with the revenue code. And there is also the miscellaneous P code that can be used, or the unlisted P code. But right now it has the status indicator in the E's, which means that for CMS anyways, they would deny it. So there's still some uncertainties in some of this coding and how it will translate from the inpatient basis to the outpatient basis, if it indeed goes to be approved for outpatient use. Also, effective August 10th, there were some new CPT codes that were published by the American Medical Association, or the AMA. The 0225U does state that it has 21 targets, and that each analyte reported as detected or not detected. So for that, each one will need to be documented, whether it was detected or not, to be able to report that code. And then they have some other neutralizing antibody procedure codes. And then I also wanted to put in here the ones that were effective June 25, just so that you were aware that, yes, these were available and they are out there. I was looking at the AMA website yesterday, and their next CPT editorial panel meeting is, I believe, October 10th. And so there is a possibility that new codes could be published by then. So we'll, send out a vital alert as we see any updates on those. All right. And then I just wanted to use this as an example, the 0202U and the one that I read before. This one also has 22 targets. And the proprietary laboratory analysis codes do represent specific manufacturers. And I did have the question come in, okay, so what if we use this test, but we're only testing for the one target? Then in that instance, you're not able to use this procedure code, because the description states each pathogen reported as detected or not detected. And you're not able to use a modifier like modifier 52, which means reduced services, because the CPT guidelines state that to report the PLA code, you have to perform, you must fulfill the code descriptor and be list and represent that manufacturer. So they're pretty specific on that. So if you're doing one of these tests but not checking all of the targets, then you're not able to report this CPT code under the PLA guidelines. But you can find another lab code that should be able to pinpoint the one target that you are checking for. So that's just kind of a caution that I wanted to go over today. All right, and I also wanted to touch base on the update to MedLearn Matters article, the SE 20015, the 20% MSDRG adjustment. So starting September 1st, to have a claim be eligible for the 20% increase in the MSDRG, you're going to have the facilities are going to have a positive COVID-19 laboratory test documented in the patient's medical record. So you have to have the results of the test, and it can be any of the viral tests performed within 14 days of the admission, and you can use tests that are performed, like if the lab test was done in the doctor's office or at another entity, you can use those, and so they're just expecting that you're going to be able to import those into your medical record. Unfortunately, it does not allow for those instances where the doctor's clinical documentation or clinical indications state that, yes, this patient has COVID-19. You have to have a positive laboratory test. And so if you have multiple, the person keeps testing negative, that is not going to fly. And CMS has also said that, if you're kind of functioning outside of that 14-day window, that you can contact them and they can make some allowances. And so what they're doing in the meantime is, if you do not have, so after admissions after September 1st, if you do not have that laboratory test documenting the positive result, then you're supposed to contact your MAC and say, hey, this claim is not going to be eligible for the 20% increase in the MSDRG. And it is not until the October 1st pricer information comes out and gets uploaded that the MAC is going to have anything to be able to kind of adjudicate those properly. So you'll be sure to work with your MAC to find out when they have all of that information uploaded into their system so that they're able to process the claims correctly. Alrighty. So just, the 14 other, if it's over the 14 days, CMS said they would consider the other complex medical factors within that requirement. So it's going to be tricky to kind of keep tabs on some of those, because the MAC is supposed to put an internal, have an internal flag that they can put on that claim so that it's not processed at the higher reimbursement. So that's kind of interesting and always cause for concern. All right, another topic I wanted to talk about is that the diagnosis code guidelines for the U07.1 is changing for the COVID-19. They are taking out the language for the presumptive positive being able to assign the U07.1. So just, that, and this will take effect October 1st. The only confirmed cases can be documented as the U07.1 for COVID-19. And so they are noting that it is an exception to the hospital inpatient guidelines regarding the confirmation. So if it's suspected or possible or probable, then use the signs and symptoms for code assignments. And it's a good plug for our ICD-10 webinar that's coming up next month. So be sure to sign up for that as well. All right. And one of the, I wish I was asleep on my job some days like that, but one of the questions that we get quite a bit is, can we bill the evaluation and management code like the G0463 or the originating site fee? And in the Medicare fee-for-service free FAQ document, they have now added a decision tree And so it really helps. So is there a distant site practitioner who's billing for the services on the list of the telehealth services and using that 95 modifier, meaning that this is a true telehealth service? Now remember, the distant site is where the provider is located. So if the physician is at home or really anywhere within the United States or the our territories like the Guam and Puerto Rico, et cetera, then they can do the telehealth site fee. And if that's the case, then you can bill the Q3014. So it's the physician is not in your facility, so they're in their home and they're using the modifier 95, then the facility can use the Q3014 as that originating site facility fee, and that is still dependent upon the patient's home being designated as a provider-based apartment. All right. So can the hospital service be furnished remotely to a patient in an off-campus provider-based apartment? Yes. So when your hospital staff is furnishing that remote hospital service, even if they're using those telecommunications technology, you can bill the care as if the care was furnished in the hospital. So that would be the either the physicians in the hospital providing to the patient whose home has been designated a provider-based apartment. Then you can bill the evaluation and management code, either like the G0463, or it could even be the emergency department visit. So it's, and then also if there is no professional service being provided, the physician is not sending in a claim for that day, but it's a service that's being provided by your nurse visit or your medical nutrition therapy, like the pharmacist, if they're doing like a Coumadin clinic type thing, then you can still bill those out on using the appropriate evaluation and management level or other appropriate CPT code, because I mentioned medical nutrition therapy, and those do have their own CPT codes that can be used. And then also if the patient's home has been designated as a provider-based apartment and you are sending staff to the patient's home, then you can bill that as if the care was furnished in the hospital, because once the patient's home is designated as a provider-based apartment, then it is in effect an extension of the hospital. All right, so hopefully that gives you some insight into that. So it's going to, really the big difference is, where's the physician located? Are they in the facility or not in the facility? And if they're not in the facility, then the physician should be billing that with the 95 modifier. And so that would be an instance where you would just bill for the Q3014. All right, so what kind of providers or services? And that, I mentioned nutrition services and your nurse visits and your pharmacist. So that can also be like behavioral health counseling, all kinds of things. But that's also assuming that the person is practicing according to your state scope of practice laws. So it's, what the intent is to allow the providers to, do is what their scope of practice and their, what all of their learning has provided for them to be able to do, to be able to provide services to the patients. All right. Sore knee, huh? Have you tried icing it? I thought that was funny, because then in my head, I hear the gingerbread man from Shrek going on. All right, so where there can be some confusion is for your physical therapy, occupational therapy, and your speech language pathology providers. This, I think CMS kind of muddied the waters a bit, and that is because they had to be creative in what they were doing to get around the laws that are in place. And so it's kind of, I would say crazy. Crazy is a good word. So for professional services, if you're doing it during your audiovisual, those can be submitted on the 1500 using the modifier 95, and then the place of service where the therapist is normally practices care. And this would be for therapists, for these providers that are in their, have their own professional practice. Now on the facility side, this is going to be where it kind of takes a turn towards the loony bin, because there's two ways that facilities can do this. So the services for for PT, OT, and ST are mostly have been added to the list of approved telehealth services, but not all of them. And so you have to kind of determine, are we going to be doing these as telehealth, or are we going to be doing these where we make the patient's home a part of the, you know, as a provider-based apartment. So, and this also kind of lets you get away from having to designate the patient's home as a provider-based apartment in a way. So if you are going to do them as telehealth, they have to be services furnished on the CMS telehealth list, and you would use modifier 95 on each telehealth service. And of course, the place of service is not necessary on the UB because there's no spot for it, which is different from the instructions for the professional claims. All right, you're also, when you're doing them as telehealth, you're not able to submit for the Q3014 telehealth originating site facility fee. And in this instance, the patient's home would not necessarily have to be designated as a provider-based apartment. All right, so deep breath. Then the option number 2 is going to be where you designate, where the patient's home is designated as a provider-based apartment. So in this instance, you're not limited to the services that are on the approved telehealth services list, and you do not use modifier 95, but you do use the modifier PN or PO. And then there's no restriction regarding reporting Q3014 for the originating site fee. So if the patient's home is designated as a provider-based apartment, you could, in theory, bill, you know, like your physical therapy services and the originating site fee. In this option, you're not limited only to those services on the telehealth list. So you do have the ability to provide more services than what's listed on that list. And it's nuts, and it's kind of, so it is kind of odd. So option 1 is to determine you're going to be doing this as telehealth. So they would have to be services on the telehealth list. You would use modifier 95. You're not able to submit for the Q3014 because the patient's home is not designated as a provider-based apartment. Option 2, is where the patient's home is designated as a provider-based apartment. You're not limited to the services on the telehealth list. So you don't need to use modifier 95, but you would use the non-accepted or accepted PNPO modifiers. And in theory, you could use the Q3014. So to me, it's a little odd in how they chose to go about this, but it is due to regulations that are currently in place, and so there is some quagmire. Yeah, it's like getting stuck in quicksand and not being able to get out. But CMS did provide a decision tree within that FAQ document, and I'll make sure that it's in the slides. The link to it's in the slides. All right, so let's kind of deep breath, shake it off. Whew. All right, so for specimen collection charges, we've got the G2023 and G2024, so that is for independent laboratories to use when they go around to the patient's house. We also have one for rural health clinics, the G0205. And then the specimen collection charges. So if you're in a physician's office or the clinic, the CPT for the evaluation and management includes obtaining the specimen. So if there is no other office visit, then you can bill the 99211. And of course, that can be for either new or established patients. They've kind of waived that for a bit. Now for the C9803, the hospital outpatient clinic visit for the specimen collection, it can be reported with other services, but it's assigned to the Q4 status indicator, so it's going to be packaged into any other service that has status indicator, the S, T, or V. So that's your surgical procedures, kind of the T is where you get the 50% reduction when it's provided with another service, and then your V, like your clinic visits. So at first CMS did come out and say, hey, if there's other services, you don't report the C9803, but they kind of took a hint from all of the questions they were getting regarding it, and they did say, okay, you can, but they did assign it to that Q4 status indicator, so it will be packaged into other services. All right, now that leads us into pre-admission testing. You can report the specimen collection, but for inpatient admissions, it's going to package into the DRG if it's within your 3-day or the 1-day payment window, whichever one that you fall into on that. So for your 72 hours pre-admission, it does not apply to critical access hospitals. And then for your outpatient admission, CMS says go ahead and report it, but it is going to package if there's the STV status indicator service on the same day, which we just covered on the previous slide. So so long story short, you can report that, but depending on whatever you report it with, it could package into the other services. All right, and I also wanted to touch base on pharmacists because this also was mentioned in the proposed rule that it isn't anything new, that because if the pharmacist is employed by the hospital, they're considered ancillary or auxiliary staff, just like your nurses and your other medical nutrition therapy stuff, folks. So it's as long as they're practicing within your, the state scope of practice regulations, any other state laws. So within their licensure, and it has to be incidental to a physician or non-physician practitioner's plan of care. And then also if those services are not reimbursed under a different payment system, like your Part D dispensing, so if they're talking to the patient, that quick consult for new prescriptions, do you have any questions on the medication? Do you have any, those types of things. And then if they're part of the opioid treatment program, those are different payment systems where those services might be reimbursed. And so for the service, it has to be under the appropriate level of supervision, mostly general. And so your pharmacist can also do things such as your specimen collections, like the 99211 E&M code for, like for Coumadin clinics. They can also do injections for flu injections, those types of things. Just if you kind of think of them of, okay, what are they allowed to do under state law? And if they have the physician kind of directing their steps, then it is something that you're able to report. All right, and then the proposed rule topics. And sometimes reading those proposed rules, I do procrastinate. All right, so one of the topics that came up in the proposed rule was, should C-9803 be kept past the public health emergency? Because it's, long after the pandemic is over, I'm sure we're going to be continuing to test for COVID. And it also is raising the possibility that the PHE will carry over into 2021. Some of the other topics that were raised was, should they just extend the use? Because the intent was to deactivate it after the public health emergency is over, or should they go ahead and make this permanent? And then some of the other language was also to make, just have it be effective through the end of the year in which the public health emergency ends. So just kind of some of the wording there, and I was in on the last CMS office hours, and just kind of some of the things that they were thinking is it leads me to believe that they may go ahead and extend the PHE one more time, which would take us into 2021. And then if they continue to allow some of the flexibilities and waivers past the emergency, that it would be through the end of 2021. So that's just conjecture on my part, and things can change between now and then. And they are proposing to make the non-surgical extended duration therapeutic services, which are like usually your infusions, to make that general supervision for the entire service rather than being initiated, the doctor having to be there for the initiation of service. And so any comments that you wanted to send in, they're due by October 5th. All right, and then the Medicare physician fee schedule proposed rule was interesting, and I'm still trying to get through it. That's kind of the procrastination part. But they wanted to create an additional category of telehealth services, but these are only for the professional side. This does not, the provision of telehealth services beyond the public health emergency was not even discussed on the facility side. So it will be interesting to see how this continues. And so but they are talking about changing direct supervision to permit the virtual, which is the audiovisual presence, to be used instead of having to have the doctor there in the office or office suite. And then also to allow other, the supervision of diagnostic procedures, to allow additional professionals to do those, such as your ARNPs, nurse midwives, those folks that are not yet able to do that. They're able to through the pandemic, but once that the pandemic ends, will that be continuing? So they're proposing to allow that, and they did mention more than the ARNPs, but I didn't want to get into too many nitty-gritty details. Now for the teaching facilities, they are also proposing to continue the direct supervision by audiovisual presence, and to continue to allow the residents to moonlight in the inpatient setting. And so what was interesting in the webinar that the AMA did was they are also proposing to CMS to allow for the the telemedicine services to continue and not be solely restricted. So once the pandemic is over, the telehealth goes back to only being, the rural providers, but they're putting forward that they would like to be able to continue to do that, even to do telemedicine, even outside of the scope of rural areas, because this allows the physicians or the physician's office to be able to do the two-way audiovisual communications with their patients that may have difficulties getting into the office, and to to be able to have those visits for folks that maybe should not be out exposed to the general public for whatever health condition they may have. Excuse me, tickling my throat. And so they would like to continue to have the telemedicine because they're saying doing this is actually increasing or improving patient outcomes, because they're able to keep tabs on their patients better and making sure they're sticking with their, their medication routines and things. And so they were also discussing that they wanted to have pay parity for those services, similar to what it would be for evaluation and management services or what have you, so that they're not losing any income. To me, it was interesting because there was no discussion of how that would be handled on the facility level. It's great if the physician's in private practice, but if they're part of a facility system, who's bearing the cost for the, the audio video equipment? If you're going through a specific provider for your telehealth services, they charge you for that. Well, who's bearing the cost for that? Who's registering the patients? Who's setting up the the phone call, the nurse's time, all of that fun stuff. So there's still quite a bit that will come about, and I think it's great. It's a wonderful way to be able to keep in touch with your patients who can do that type of, where that type of service is helpful, but also then it to me leads me down the path of thinking, okay, but what about when you have, your medical nutrition therapy, your registered dietitians, your folks on the facility side that are not able to use the professional claim, but the facility claim form for their services. And at this point, I didn't hear any discussion on that. So that will be something that you might want to keep an eye on, or get in motion. All right. So, Dusty, that was the end.
Yeah.
The end of the. All right. So I've got yes. All right. So the I do have a link to the Remdesivir emergency use authorization if you need to read it. The second one, those frequently asked questions, that document is updated a lot by the by CMS, and so that does have the decision tree for the G code versus the Q3014 code and the physical therapy, the PTOT SLP services. And right now, it's on page, the G0463 versus the Q3014 is on page 126. But that may change. That will probably change.
Okay, great. Well, it's great content. We already have a lot of questions that we'll try to get to as many as we can live. But again, if you do have questions, you can submit those in the Q&A panel. We'll try to get through as many of those as possible. I'm talking fast for a reason, but we will be sending out the slides. We had a few questions about that. You'll get the slides. You'll get a link to the recorded webinar so you can rewatch it. And we have a number of articles and previous webinars on a lot of these topics that we're getting questions on. If you go to vitalware.com/COVID-19, no hyphen, that's where all of our billing and coding resources are specific to COVID-19. So you can check that out, or just go to our resources section on our site and you'll find it there as well. And we'll also be sending out, for you attending live right now, you get a PC CEU, so you'll get notification on that as well. All right, let's dive into some questions here. If a patient receives remdesivir infusion while in the hospital, what type of procedure should be linked to that coded infusion? Can this only be charged on IP accounts, or can it be charged on observation accounts as well?
Well, for remdesivir, it's only supposed to be used when the patient's an inpatient, and that does not include patients that are observation patients. But I would need to double check the emergency use authorization. But at this point, since the emergency use authorization only covers inpatient, you would only be able to use the codes that were, sorry, I should have, let's see, there's two of them because they've got, whether it's peripheral vein or central vein. So they've got the XW033E5 and then the XW043E5 for the central vein.
Yeah, so somebody also asked, is there an administration or procedure code of some kind required when administering remdesivir? So
yes, these, yeah, no warning. These came out the 31st saying you can use these August 1st.
All right, next question. Do you know which code would apply to the Abbott 15-minute test?
For that one, I would have to research and get back to you so I can make sure that because I don't know that one specifically off the top of my head. So I can look that up and give you the answer on that.
Sounds good. How will CMS Max know about the positive COVID test within 14 days to apply the 20% increase in DRG reimbursement?
Well, if you're coding it with the U07.1, they are going to automatically give that 20% increase. And so that's why you're going to have to call them and say, hey, I don't have the lab work, the positive test in the chart. And so we don't get the 20%. So yeah, they're putting that in your hands. And after the pricer is effective October 1st, they said, CMS said that they would provide additional guidance. We have not seen that yet. And the inpatient final rule, we usually get in mid-August has not been published yet either. So they're running behind on things.
Someone mentioned they don't understand what you mean when you say PBD.
Oh, sorry, that is ProviderBased Department.
So hospitals can charge for defined telehealth services in a patient's home, provided they have submitted the home address to be designated as an outpatient department of the hospital. They're looking for confirmation there.
Correct. Yes,
Okay.
that is correct. Yes. We have, well, there is a previous question in our COVID resources. If you are a subscriber of VitalWare, there is a Vital Alert that we've done that has the information on how to do that. And it's also a question in My Advisor. So you can find it several different ways.
Yeah, we also public facing. We have a great recent article on G0463 and Q3014 clarification. So check those out as well, along with the modifiers with those. So, how do you designate a patient's home as provider based?
Okay, well, that's you have 120 days from the date of service to be able to do that, and basically it's sending a list of addresses to your CMS regional office. And so frankly, I don't know, and it's kind of funny because this came up in the CMS after hours call. Somebody said, you know, well, what are they doing with these at the regional office? And, you know, because, you know, those poor guys are probably getting inundated with addresses, and it was kind of you kind of got the impression that they're really not doing anything with them. That was just a way to circumvent the laws that are in effect. So I know some of the regional offices are going through a few of them, but I can guarantee they're probably not going through every one of them.
Sure. All right, this is when you were discussing, you had option 1 and option 2, I think, around the telehealth services. But for PT, OT, and SP for option 2, would you just bill the regular CPT codes for the services provided and not Q3014?
Let's see. Let me get to, here we go. Option 2. So option 2, you could bill the Q3014, but you are getting the reimbursement, you know, your regular reimbursement for the services that you're providing. And, you know, but you can still, you know, so if you are having an additional cost for, you know, the telehealth equipment, you could use the Q3014. So it's really just to help you get reimbursement for any costs that you're incurring while providing the services. Great.
So what ICD-10 code would you use for pre-admit testing when a COVID test is performed, same encounter as procedure?
If they are experiencing, well, it's a pre-admit. Did you say it was pre-admit?
Yeah, would you use for pre-admit testing when a COVID test is performed on the same visit as procedure?
Yeah. The same pre-admit diagnosis that you would use for other lab tests that you're doing at the same time. There hasn't been any specific guidance come out saying to use, you know, any other specific code.
Another pre-admission testing on outpatient procedures, not within the same day. Pending negative COVID results. I didn't read that quite right, but
okay, yeah, yeah, because what's happening is that when somebody's going to have a procedure done, they have to go like a week ahead of time to get the COVID test. And so you could still use the same diagnosis that you would for the pre-admit testing, or if they're exhibiting signs and symptoms, you could use those. And so those, since it's outside of that payment window, then it is possible that those would be reimbursed separately. But a lot of that does depend on some of your payer contracts. CMS would pay it because it's not on the same day, so it would not be packaged. But for other payers that have a longer span, I know the last time I had surgery, my pre-op stuff was a week ahead of time, and they packaged it into the surgical procedure and didn't pay it separately.
So kind of good segue. If COVID testing is done before surgeries and are done a week before the surgery, should the test go on the surgery facility claim, or should it be on a separate claim?
It could be. It's dependent on what your policy is now. So if you send those out, not on the surgical claim, you can send it out ahead of time.
Okay, great. We probably have time for like 2 more questions, and then we'll have to get going, unfortunately, but we will download all the questions and make sure that they get in the FAQ report that we send out following the webinar. Next question is, for critical access hospitals, does the 20% adjustment apply as CAHs are not reimbursed by DRGs?
Unfortunately, no. And I would have to go back and look to see specific for critical access hospitals so that I don't misspeak. But since you're not reimbursed under the MSDRG, then you would not get the 20% MSDRG increase. But I am having difficulty remembering what kind of increase you're getting. So I will double check that and make sure I let you know.
All right, this will have to be the last question live anyway. Can provider charge A&M if he is performing the collection of tests?
Yes. So if the physician is collecting the test, that could be charged with an E&M.
Okay, that's unfortunately all the time we have today to answer live, but we'll send a link with your CEU certificate, a link to where you can find and download the slides, as well as rewatch the webinar on demand if you need to. And then once Ardith works through the remaining questions in her team, we'll make sure to include those, and that will be at the same link as the recorded webinar. And the slides, we can't guarantee it'll happen at the same time because it takes a little bit longer to get through those and make sure we answer those with a well-researched answer. Again, we do have a COVID-specific billing and coding spot on our public-facing website for anybody that wants to go there. You go to vitalware.com/COVID-19, or just go under the resources section of our site. You can find that there. Otherwise, another good way to stay in touch with the resources we're putting out is through our monthly newsletter called The Mid, and you can sign up for that at the footer of any page at vitalware.com as well. Thanks again for attending today. We do have a few more webinars coming up in the next few weeks if you want to check those out and sign up. Otherwise, have a great rest of your day. Thanks all.
Awesome. Thank you, everybody.